what Twin has said, I think I'm also back home. I'm called Natukunda Sylivia. I'm a nurse at the same time as an EMT, working at Mbara Regional Referral Hospital. I also work as the Deputy Emergency Medical Services focal person for Mbara. And at the same time, I'm the WHO Basic Emergency Care Facilitator. I'm aspiring to be the Master Trainer for WHO in the BEC course. I thank you guys, especially to the Busoga Forum, and I'm proud of you because my emergency practicing started from Busoga. I worked at Jinja Regional Referral Hospital, where I've met so many mentors on the Busoga Forum. So I'm really humbled and I'm happy to come back and I share what those people implanted in me at the beginning. I wish you a nice hearing and sharing and learning from this presentation. Thank you.
Thank you so much, Sylivia, for that introduction. As you've heard, she's a senior in pre-hospital care. She has been in the system for some good years. And I'll again re-echo. We are not experts. We are moving step by step to ensure that EMS grows. And don't be offended that maybe you don't know this and that. We've been practicing this, but we want everyone to come on board and do especially pre-hospital care, because this emergency response care for accident and trauma victims in most cases saves lives. Before this EMS, people used to die on the road. They didn't know where to communicate, but we are like, as Busoga Health Forum has done it, we are trying to sensitize members to see a way of communicating and shortening time in response. So by making calls, we can always see that help is brought to you in the shortest time possible. So for now, because of time, we shall need to know the topic. And the topic for today, we know it is pre-hospital care. Pre-hospital care, what does it mean? This is the care you get, a casualty or a patient gets before reaching in any health facility, whether clinic or a hospital. So that is what we call pre-hospital care. And allow me call back my co-host, Sylivia, to give us a short presentation so that we know how it moves. Maybe it was an experience. If it is an experience, can you do it? If you were there, would you save maybe some lives? Over to you, Sylivia.
Thank you, Winfred. As she has said, we are not experts in this. We are just building a system and we are starting it from scratch and from the mentors. So I'm going to give a case presentation. This is a case that I've done it myself. I was involved in it from the beginning up to the end. Among all the emergency responses we've done, especially in Western region, we've had so many. If we talk about Christmas time, you saw how the roads were crashing, accidents all the time. So when I was given this opportunity, I thought about a case I would come out so that we can understand what pre-hospital care is. That care you can give to someone before you reach the hospital or to an advanced hospital. So this is a case study of a major incident that happened along the Antonde Churhura Road, that is in Mbara region. At 1 p.m., the focal person EMS Mbara region received a call from the bystanders along the Antonde Mbara Highway reporting an accident involving a Toyota Wish car. A car had fallen in a river with about 8 occupants. 1 kilometer shortly after Lyantonde Hospital as you head to Kirhura. The accident happened as the driver who was overspeeding in a muddy road tried to create space for a truck that was coming in front of him to pass. And in that, the man lost control and the car fell in a river. The caller did not know the condition of the people as the car was immersed in water.
Next slide, please. Next slide, please.
Sylivia, I'm sharing the screen.
Yes, please.
Madam Winnie, we can be talking through as we.
Oh,
I think
Yes.
I'm back.
Okay.
Yeah, apologies, I had challenges with the network, you know, our IT thing.
It's understandable. Kindly proceed.
go on, Sylivia.
So on the scene, patients were evacuated by police, ambulance teams, and the bystanders. Hazards surrounding the scene was rain, muddy road, and a swamp. The patients who were evacuated, the black code was black color were 2. They died on scene before evacuation from water. Yellow color, 3 patients. Green color, 3 patients. Patients were moved to the Lyantonde Hospital, almost 1 kilometer, resuscitated by ambulance teams and staff. After stabilization, the patients were transferred to Mbara Regional Referral Hospital for further monitoring and higher dignity care. So first aid on scene, because the first aid was scene safety, triaging patients according to the severity. Remember this, we had hazards on the scene, so and the hospital was very near. Those patients were moved. It was almost less than 1 kilometer to the Lyantonde Hospital, and we could not do resuscitation. So when we moved patients from the water, quickly we put them in ambulance. We started resuscitation from the Lyantonde Hospital. We allocated patients to different teams of ambulance, approached the patient using the primary survey as our ABCD. We had these were patients who had drowned in water. We had to assess how were the airway. In that time, they were moving in water. They were knocking their necks. We wanted to see where they had any cervical injury. They were inhaling water. They were swallowing water. We wanted to hear how their chest was, how are their oxygenation. Remember that people had died, so we had determined the severity. The circulation, no one had, we didn't have anyone who had, let's say, they were not in shock. Majority of them lied in E. Most of them, they had low temperatures. They were shivering because of that water. And we had to clean them, warm them, give them antibiotic cover, like so many. We had to resuscitate, stabilize the patient. And after then, we moved the patient to definitive in Mbara. So when we finished the resuscitation of the patient, of course, we had teams from the Antondi hospital. When we rushed in the hospital was shaken. So we had to get other teams to come on ground and help us. But after we had to go in, after we resuscitated, all our patients got stable. Those ones who had low temperatures, they became better because people had to go buy new clothes. We buy new blankets, got them hot food that bring for them tea to take. Really, doctors assessed them, patients good enough in hospital, doctors were there to help us as pre-hospital. The time we reached the actual, we as pre-hospital and the nurses were there, were the first people to respond, and doctors came from theater and joined us. So after we had a debrief meeting, what went well, what went wrong. So we realized that our ambulances were well equipped because we had 2 ambulances that were type B, and we had another ambulance that was little type A, but the type B ambulances had everything. We had our blankets in, we had our bed sheets in, we had the syringes, the gloves, we have the gauze, we had almost everything in ambulance. So we found out that the hospital where we had run to, because the place was muddy, was not safe for us to resuscitate. They even had shortage of sundries, but because us emergency teams were prepared enough, work went on well, and we supported every team, and the situation was calmed. There was timely response, despite the ambulances being dispatched from far. Mbara City, Chulhura Area Center 4 is kind of very far towards the Antondi Hospital. But we realized because the team, all of us in Mbara, we have tried to alert ourselves. We've tried to create a system that is working better. When I just got a call and I posted it on the group, everyone was alert. The children ambulance I knew was the nearby and being equipped one, maybe it can rush to Mbara. So the team rushed and they were the first one. In 20 minutes, they were on scene. And they really found the police people had just started evacuating patients from the water. So in 20 minutes, we thought, really, despite our place is very far, we tried. Then the teams were experienced and they knew what to do. Of course, this scenario happened. These are the people who got in an accident, who got involved in this water when they were going to bury a relative. And in the long run, they also had to lose more 2 people, which was really sad for everyone. People who were at the burial had started coming. People who were in the Antondi, their friends had started, almost the hospital was full. But because us, we knew what we wanted. Actually, they wanted us to continue and take them to the private hospitals in the Antondi, in Mbara, but we calmed them and said, we are here to work. And we started working, and we didn't even shy away that we don't know the Antondi because we are ambulance teams, we are from Mbara, Chulhura. But because we introduced ourselves, we had our uniforms, we were smart, and everyone would recognize that we are from Ministry of Health and we are doing work. So it became easier for us to control the situation and even the resuscitation. Patients were stabilized, cancelled, and explained the need to move them to the higher facilities, because when they got stable in about 4 hours of resuscitation we had, as being in the hospital, we couldn't rush to other hospital. It was a general hospital. So we said everything can be controlled here. But for them, when they saw themselves, some getting stable, they were like, no, we need to go home. Some, of course, wanted to go to see what how the burial had taken place, but we assured them and counseled them the need for them to be monitored for about 24 or 12 hours. They had to sleep at night. So they were from very far. Those people were from Ntungamo and they were going to Hura. So we had to tell them, we are moving you to Mbara Hospital, being a nearby and a high specialized hospital. We monitor you and we are here for you to take you. We are not charging you money. Our ambulances were there. No one had moved away. Even the people behind us were on standby. So that in case of anything, other ambulances had come for the Antonde, we move them. So we canceled them. So attendants were allayed anxiety, especially those who were shaken after hearing the ones who died on spot. Definitely we canceled them. Recommendation. We would like to strengthen our police partnership because we got a call from a bystander and we don't know who called the police. So we realized that there was a gap for us. The time police was called, if we had the person in police of Riantonde, they would have called us faster so that the time they dispatch their police car to reach the scene, one of our ambulances would have also been dispatched. So we created that, we had the police people and we even brought them to our group of WhatsApp. And that's what even we do, even the incidents of cabaret, when we have such incidences, we come together to look for police people. How do we work together? Then to enhance emergency response across each health center for and general hospital. We realized that as ambulance people, we did a great job for that hospital. Really, it was in shortage of sundries. As being at a hospital, it was going to look bad if us also ambulance teams, we had nothing. Even to reach on the scene would not do anything because we are the people who gave gloves to the people we found in the scene, the ones evacuating. So we recognize ambulances should be equipped and those people in the health center should be equipped, should be taught what emergency is, whether those EMS teams are there. At the end, they asked us, we didn't know this team exists. So you saw, like the press was not ready. Then community awareness about EMS, especially ambulance services. We need to create more awareness to our communities to really know which ambulances are in their community. Because at that time, we never know. There could be another ambulance that was near that area. The time they called us because we had worked on them somewhere. If they had another contact that they knew and it was near, they would have called. Then we ensure ambulances are adequately stocked and ready to respond. We achieved all this because it was teamwork. At the same time, we achieved it because we had our ambulance well equipped with everything, and we are not worried of anything. So the pic on the left, that's the pic we took in the Antonde. Then the pic on the right with the police people, that's the debrief we did in Christmas time in the crash of 2 buses of Rwanda that got an accident in Kabari. So after we had to go and do a debrief, the person next is my coordinator for Kabari and the DHO and the police for Kabari. I thank you very much. That was the sharing. We had so many, of course, we had really responded so many experiences, but that was the short I could raise up. We can have a learning, and we know that it can create something. I know that there are EMS services. At this time, I request questions and I hand over to you, Winnie. Thank you.
Thank you so much, Sylivia, for that response. Thank you, Busoga Health Forum. Always caring, always here, because people's lives matter. Yeah, I think the participants, you've had that case scenario. It was real, of recent. And if you've noted, if you have some queries, some questions, please, I would request you use chats, but be brief. And then we shall accept hands later. But at the moment, let us use chats as we continue with our session. When you look at that scenario, I know everyone can do his or her level best to save lives. Maybe the first concern would be, it was a place which was not easy maybe to reach. Remember, the vehicle fell into water. The place was swampy. She has told us it was muddy. And but they had to do their level best to save lives. Maybe out of those, we would have lost all of them. My question is for the participants to know, or those online. Madam Sylivia, can you maybe briefly take us through on how the team managed to triage these casualties in water, maybe, or did you get them out when the bystanders had pulled them out of water? And then in triage, is it the same like pre-hospital and in facility? Enlighten us more on that so that our participants can be on the same page. Thank you. Over to you, Sylivia.
Thank you very much, Winnie. So for that triage, it's the police that was doing that work and other people to remove those people from water, because definitely the people were immersed in water, the car was immersed in water, they didn't have that car to lift the car. So people had to dive in that water. As like EMS, we could not go in. We had to wait for them to come to the scene, to the ground. So when they reached the ground, definitely down it was muddy. There wasn't like anything. The first two patients, they moved out. Those ones were color, they were yellow. Then the rest, as they come out, our ambulances would get them, put them in ambulance direct. As we go assessing, we continue to the hospital. Because the hospital was very near and the place was too muddy. Besides, there was nothing, like it was muddy, then swamps, water, it was kind of dissolving. So we rushed to the hospital. So when we talk about triaging patients in hospital and pre-hospital, they kind of differ, because as in pre-hospital care, we are not experts. And in hospital care, still, remember, they're also not experts, but you have to think about, we are using our ABCD as our model to do our pre-hospital care triage. We have to look around and see these patients. Let's say this was a case of patients who had drowned in water. So what could be our worry? Our worry was the airway, our worry would be B. We couldn't worry more of maybe C, because we could not show what, but could be. So we moved on and assessed the A. The time the car was falling in water, the seats were moving here, there. We identified patients. They had neck pains, but no one was complaining of severe pain. But we stabilized them. At that time, we thought about putting a C collar, but we did not put, because they were talking. Their airway was okay. It was patent. We tried to hear their chest. No one had swallowed much water, like we couldn't hear those abnormal sounds. So the only thing they had, it was shivering, because majority, the lower side, they had immersed themselves in water. The people who swallowed water, the people who were seated in front, these people behind, their worry was the backache. They had worries of the leg, being our people, they are kind of fat, but they were stable. But being fallen in water, they were shivering. So we did that sorting. We assessed our A, B, C, D in that way. We saw that circulation, they were circulating well, their capillary fluid was okay. They didn't have any signs of shock. So we moved on there. On our D, they were stable. So we went on exposure. It's when we started taking their temperature, and their temperature was around 35 there, but shivering. So when we started bringing the blankets and giving them oral some tea, reassuring them, giving them painkillers, they got stable. So, but let's say in other cases where like an incident of cavalry, it is the best example that could triage. We had so many, we had 4 people who died on spot. Actually, they were not 4. We had 2 drivers who died, the 2 conductors, then the 2 attendants who died on spot. Those ones who couldn't get them. But we had other patients who had severe head injuries with their neck, or even their neck were injured. So those patients were our first patients. The first 4 patients, we evacuated them after seeing the severe head injury. They were not conscious when they were pulled out from under the vehicle, and they were moved. They were the first people to be moved to the nearest area center, then we were moved to cavalry. Then we moved to those people who had fractures. Many of them had fractures. Then the rest had minor bruises, because we had about our green patients who were like 54 and about like 16 who were color yellow. Then the red ones we had were 8. So that's how we triaged them. The incident of cavalry, it was too massive. So, and when they reached the hospital, already we had told them these are patients who come, we had put their C-collars. We had redone dressing, but when one of the patients reached the hospital, the doctor, they triaged, of course, they continued triaging their patient, but he had to go and assess. So when he went in B, he realized that the patient had an pneumothorax. So he had to go in and put in a chest tube. And for us, we had not picked it out in the time of our triage as pre-hospital. We didn't have a stethoscope or scalpel or percus. We didn't rule out an pneumothorax, but the doctor in cavalry, for him, he ruled it out. And they went on to do other investigations. So as our triage, we may say, yes, all of us, we are red, but we may look at those first things that can show us this patient is red, but however, we can miss other things. But we try to make sure we do A, B, C, D. Thank you, Winnie.
Thank you, Sylivia. Hope we are all on one page. Yes, this is Busoga Health Forum, and we are here to learn or to share experiences. We said questions on chat, concerns on chat, and we shall air it out. We shall give other stakeholders chance to say something and maybe have some additions. But as you realize, when Sylivia was presenting, pre-hospital care means you must be ever ready. Anytime you are called upon, anytime life is going, anytime life must be saved, and you must work as a team. There is multidisciplinary in pre-hospital care, and there is connection with in-facility, because continuity of care must be reassured to the attendants, to the bystanders who called you, to your colleagues, and to yourself. So we say triage is a must. Triage is everywhere. Triage helps you to know who needs attention faster, because you triage according to severity, as she says. Then the team must be knowing the roles to play. That is what I've picked in her presentation. You must know what to do. Don't be an escort. Even a child can direct you to do something you might not have done. And we deal with life-threatening conditions. Our aim is stabilize this patient, this casualty, until you get care. But as you are doing that, we encourage you to always communicate with specialties, communicate with people in facility. If the distance is far, you realize these casualties were taken to Lyantonde first, a general hospital, before proceeding to a regional referral. Why? Because each life matters. Reassessment of these patients. Whether the patient is talking, please always reassess using the ABCDE approach, whereby we're told airway, breathing, saturation, disability, exposure. Remember, these people had fallen in water, so there was risk of hypothermia. They had to cover these patients. If you don't cover them, it means they'll get arrhythmias, and that will lead to cardiac arrest. So as you work or as you implement, always think faster to stop the other complications like cardiac arrest and eventually which may lead to death. Team Kitugum, Team Gulu, Team Barara, Masaka, Team Jinja, Team Mbale, I've seen you online, and the rest of the country. Thank you for attending in big numbers. Let's continue with the program. At the moment, I would encourage everyone to join Emergency Society. Why? Because we learn a lot from there. We said we are still babies, but we are growing. Before we were just born, we are, I think, trying to walk or take steps through our leaders, that is the permanent secretary of health, and then our commissioner EMS. We thank them for that. And of recent, we elected a new president for Emergency Care Society of Uganda, that is Dr. Doreen. So there is a team. There was a concern on the forum that are protocols for triage approved. Sister Sylivia, I don't know whether you have that answer. This was from Dennis Nyambani. Do you have adopted standard triage protocols? I think this applies to Uganda. I would answer, but maybe you can answer that briefly. Or we are just trying to struggle with any triage system.
Thank you, Winnie. It's right and it's good and true. We have the Uganda triage treatment algorithm. In last year, 2021 August, we cascaded the training across the country, where every region, even Busoga, come to Jinja Hospital. Once you enter the hospital, you should be able to see the big post of triage, that the color codes, whether they're indicating yellow or what. We gave them that course and we disseminated the charts. So we have our own Ugandan triage treatment algorithm, where it categorizes who are the patients that follow under red. Those are the most critical and the severe patients. Who are the patients that fall under yellow? The ones with moderate injury. They are not too severe and they are not too mild. And those patients with green category, green color, the ones who are mild. And someone was also asking who are the black patients. Black color are those patients who died and they go to the mortuary. So as pre-hospital care providers, at that time, we think about our ambulances. When we reach the scene and you find the codes are broke, you are not the one to carry the patients to the hospital, because our ambulances, type B ambulances we have in the country, they don't carry dead bodies, please. People who are carrying dead bodies in ambulances, they are under beyond our policy. So people who are coded black are the people who are died. People who are coded red are the people who are more severe and critical. People who are coded yellow are the people who have moderate. Then what else, Winnie? Any other question you had said?
I think
Someone was asking how EMS is funded in Mbara region. EMS, it's not funded in Mbara region. EMS, Emergency Medical Services, it's a system, it's a department in the Ministry of Health. Maybe, I wish at some point, Busoga Forum, I saw Dr. Marion, they will invite her and the commissioner to talk about EMS, the leadership style, so that they talk about the policy. We have a policy that was launched. So it's the one that is implementing the system in the Ministry of Health. And it's the same system incorporated in the service delivery, whether in PNFPs, because public hospitals cannot work without government. So like in Mbara now, it's our mandate as the hospital to utilize emergency medical services. We have a school, a university that teaches emergency physician. You heard about Win telling you she got training from Mbara Hospital. So as the hospital, they support us as EMTs, as implementers, the director of the hospital administrator, the human resource, they support us as ambulance people. They are on our groups when we had problems and we say it on the group, you find they are supporting. If we run out of oxygen, we wrote to the director, I find it supporting. So it's not the director of our hospital that is funding the system. It's the system we are practicing as the way we do our day-to-day work as health workers on ward. Except that we give in extra hand because I'm a nurse. At the same time, I go and move on ambulance. Still more to that, I don't stop there. I can receive a call and alert colleagues and we move. As our system develops, we develop a line that will come, that will be uniform in the country, and maybe we can be. So someone is asking where the tools were adapted. When you go on those tools, when you go on that UTAT tool, down you will find so many people, Walimu, Emergency Care Society. There are so many people who were there, who modified and came out with that. Thank you so much.
Well, thank you so much, Sylivia. Members who joined late, you are welcome to this forum with meaning, forum with knowledge, ready to serve you at all times. And all the aim is saving lives. Right now, I would open, though some questions have been answered, but I'll open room for like 6 questions because of time, and then we shall give time to other people to give us some more updates about EMS. And I'll begin by looking at, there is someone who said is interested in joining EMS. I would like to tell you that just like you've logged in on this Busoga forum, it means you've already joined EMS. You are not supposed to stop here. You are supposed to continue giving care or help or advice, and also sensitizing the community where you are that in EMS, this is what we are supposed to do. In case of an accident, don't just come to steal items, but look at someone's life first. Because sometimes you end up stealing things from your own relative. Reaching home, the person died, you are the one having the property. So it is so embarrassing, but joining EMS, it is a will. Begin by showing interest, by being active. Through this forum, you now know the contact people. They will help you in case you want to specialize. Like I said, for me, I specialized in emergency medicine, diploma level and Ambarra University, meaning, and went for fellowship in Korea. So it means I also started with interest. You can always apply for a vacancy and then go for further studies. I don't know your level, but if you're a doctor, you'll go in for masters in emergency medicine. There is always room here and there. Those with the diplomas, the bachelor's is also coming up. I have someone say who wanted to know the mapping. I mean, was commenting about mapping all partners. EMS, I think this has been done by our commissioner, Dr. Wanyai John. They tried to identify people with ambulances, especially type B, not type A. Type B, type A is that ambulance which is like a box, like a taxi. So EMS is advocating for type B or type C, that is advanced ambulance. And all these ambulances are being brought on board so that in case of such a scenario, these people can be alerted and come on board, drive to the scene and rescue patients, but with the coordination. So that is what is being done. Ambulances in private practice, police, like in Masaka, we've trained the military, UPDF, we've trained police. We are one because we are now partners as more people come on board. Maybe the challenge is politics, but we can't go there. You cannot avoid that. What we are after is saving lives. I would like maybe to invite someone from the Busoga Health Forum, doctor, to maybe give us some light on EMS in Busoga region. How are we doing the pre-hospital? Are we managing it the way we are doing it this side? I'm just giving like 2 minutes only. Thank you. EMS in Busoga region. Elizabeth?
Thank you very much. Dr. Mkembo, are you or Dr. Kabura, are you in position to talk about Busoga region?
Thank you very much, Namara. I think the right person who would be talking about EMS in the Busoga region is Marion Nacheyune. And she's our partner here in Busoga and then the ministry. So I think we shall give her that time when it comes. And I'll leave it at that. Thank you.
Okay, thank you so much. So according to, thank you so much, Dr. Wilberforce. According to our chats, majority of members are just thanking for the session. Majority have managed to log in. And there are those who are even giving some light in the EMS on how to move on. Thank you so much, members, for that. That means we are all active. It is not switching on. Something shows that you are online and you move away. Thank you, Okecho Emmanuel. Thank you so much. I thank Mbuga, George. I salute you all, Teresa, Atuhire. We are getting your messages. Most of these people have been online for, they say we've been attending. We thank all those who have been attending and continue attending. Stay online until the end. Right now, I'll give some hands in case you have a question, you can put up your hand. Then after answering, after giving you a chance, unmute, talk, and after talking, please put down the hand. Otherwise, we shall get confused and select you again. Yes, I see Baruch Nathan. Baruch Nathan.
Yes, please. Thank you so much.
Yes.
I had risen in my hand. I was almost getting tired.
Oh, sorry. I was on chats first.
First of all, Busoga Health Forum, thank you for taking this mantle to welcome us. My name is Baruch Nathan. I am a member of the Emergency Care Society of Uganda and a volunteer of EMS based in Mbarara, and I work as an ambulance assistant. Sylivia Natukunda is my focal person, and I want to thank her for this presentation. At some point, really, it is opening up our minds as who are in pre-hospital. I want to say something small. From the presentation Sylvia has given us, it clearly shows that pre-hospital care is a collective effort of everybody, right off from the bystanders, the police, and all those people who are involved in the response. But I have a few reservations. On most emergencies that we have responded to, especially road accidents, there are only two types of ambulances that arrive: the Red Cross ambulance and then the EMS ambulance. When the police arrive, it is usually the traffic police or the police with that car which is for patrol. And we are aware that, yes, and we are aware that the police has ambulances, and it has also people who are partially trained in responding to emergencies. I would request that our focal persons, please, you could engage these people to not only be responding to emergencies with guns, but also with people who are trained, because we are aware they are PASAO there in police. Then the ambulance is owned by MPs. I have never seen one. I only see them getting involved in accidents, carrying the dead bodies. I can request EMS to look for how they can bring them on board so that we have something uniform. That was my observations. Thank you very much.
Oh, thank you so much, Nathan. Kindly put your hand down. Yes, you've talked about that. My experience in Masaka region is that at least before, police used to use those patrol vehicles to carry these casualties to our emergency department. Sometimes they reach when they've been suffocated, you know, the positioning of the neck. As in the presentation, they said airway management. So it's because they were green, we couldn't say this and that, but we trained them, and our police generally is working together with us in Masaka, and they're using an ambulance. If you remember a few years ago, our military partners, UPDF ambulance, got an accident when we had gone to rescue casualties from the highway, Kampala-Masaka highway. And maybe the regional commander should come on board and help you with the police to be on board. Otherwise, Red Cross is countrywide and is doing tremendous work. We thank you for that. Another person talked of difference between ambulance type A, type B, type C. I talked about. Type A actually has a lot of nothing. These are the ordinary ambulances even politicians bring about. And you cannot resuscitate a patient who needs maybe oxygen and what have you. It's like a box, like a taxi, transporting passengers. That is the type A. Though people mistake A to be advanced, but A is the ambulances EMS has banned from carrying our casualties. Type B is that these ambulances you are seeing, they're equipped inside with the equipment and supplies, and they can offer oxygen. There is partitioning between the back and the front where the driver sits. And there is a glass where you can see what is happening in the behind cabinet. The type C is the advanced where you can intubate a patient, transport a patient. That is like a mini ICU on transportation. That is what I can say in these few minutes. Thank you. Maybe Tiondi. I think because of time, I'll say please next time. Sorry for that.